Welcome. This is Dr. Lani Simpson, and today this webinar is about osteoporosis medications and insufficiency fractures. A couple weeks ago, I had a webinar and we looked at femur fractures with Dr. Jennifer Schneider. Today we're going to talk about insufficiency fractures, which are less known. I'm going to do a short discussion about bone so that everybody knows what we're talking about in terms of bone anatomy, and then I'm going to be bringing on our guest, Sandi Putnam, to talk about her personal experience. So I always like to mention my book, which is Dr. Lani's No Nonsense Bone Health Guide, which is available on my website and Amazon and probably your local stores. The life cycle of bone. 80% of our lifetime bone mass is laid down before the age of 18. This is why it's so important for us to get information to our children, to the mothers of our grandchildren. That is the most important time to build up a good bank account of bone. After the age of 30, it takes more time to build and maintain bone mass. So what makes bone strong? Well, bone density is certainly a part of it, and that's mostly what we've been hearing about in terms of the measurement of whether or not our bones are healthy. We hear about this bone density testing. And yes, bone density is one of the most important pieces of information that we have regarding how healthy our bone may be, but it's not the only thing. We need to have good bone density, but the quality of our bone needs to be good too. So to give you an example, you can have two people, same bone density. One might be fracturing easily, the other one may not. Well, maybe the one that's fracturing easily could have a genetic problem. Maybe they are not eating well. Maybe they're smoking cigarettes. There's a number of reasons why the quality beyond the bone density alone might not be good. So this is really important and I think often missed, certainly in the medical model. We're really going to be talking about two cells here because that's how medications generally are targeting in one way or another these two cells, these bone cells, osteoclasts and osteoblasts. So the osteoclasts get rid of old bone. That's how our bones stay healthy. They go after old bone, they chew it up, get rid of it, and then these osteoblasts lay down new bone. Well, when we're younger, the osteoblasts outpace the osteoclasts, and that's a good thing because we build our strong bones, and by the time we're 30, we're really not doing that very effectively anymore. You have to put more effort into it just to maintain bone. So after the age of 30 and every decade after that, it's more difficult to gain bone density on our own. You can do it, but it's going to take some work. So the osteoporosis definition, and this is one that I live by, and this was put out by the National Institutes of Health in 2001, and it still doesn't seem to filter out a lot to the medical community, but osteoporosis is a compromised bone strength predisposing to an increased risk of fracture. Bone strength reflects the integration of two main features, bone density and bone quality. So we want to have that bone density and bone quality, or that, again, the flexibility. And no matter what we do, the older we get, we're going to have less and less of that flexibility in our bone. But we can impact that bone aging process, if you will, with good nutrition and healthy gastrointestinal health, etc. So there are ways to help with that. In the early 90s, the bisphosphonates came out. Fosamax was the first one that really hit the line, and this was going to be the savior, basically, of all of our bones. And, well, unfortunately, there were problems with these medications, and they target, actually, the osteoclasts. Almost all of the drugs now that are prescribed for people who have osteoporosis are in the category of bisphosphonates. So Fosamax, again, is one of them. Actonil is another one. Boniva, these are the common names. Boniva you might know because Sally Fields, she advertises it on television. There are a number of actresses that are advertising these bone drugs. And then there's reclass, which is the IV injection. And early on, by the way, the Fosamax was given every day, and they found other problems with that. But usually it's a once a week dose or a once a month dose or maybe every 3 months or yearly. Then there's another drug that sometimes is put in the category of bisphosphonates. Technically, it's not. Prolia works differently. It's not a bisphosphonate. But what it does do is it does a similar thing in that it impacts those osteoclasts. So BPs, or the bisphosphonates, suppress osteoclasts. And osteoblasts lay down new bone. Well, if you overly suppress the osteoclasts, you're going to end up with what? Like, say you've been on these drugs 5, 7, 10 years. You're going to have more old bone left. Osteoclasts have not been left to do their job to get rid of the old deteriorating bone. And by the way, that goes on about every 7 years. That our bones, and more so as we're getting older, longer length of time, but every 7 years when we're in our younger years, we basically almost have a new skeletal structure because the osteoclasts get rid of new bone and the osteoplasts uh, lay down new bone, and that's the way it's supposed to work. So when you interfere with the natural process and do that too effectively, you can end up with major problems. So the troubling adverse effects of bisphosphonates. We talked about in the last webinar that I did, the osteonecrosis of the jaw, which are areas of bone death in the jaw. This was the first thing that was uh, associated with Fosamax, particularly if somebody had had some dental surgery. If they've been on these drugs for a while, they would find that it wouldn't heal well, and in some cases it was very significant. There have been cases where people literally have lost all their teeth. Those are, again, it's a small percentage of people, but one thing I like to say is that when it happens to you, it's 100%. So we don't want to take these things lightly. Atypical or non-traumatic fracture of the femur and with delayed healing and can be bilateral. We talked about that with Dr. Jennifer Schneider, who presented twice to the FDA on this issue. And there is that webinar available to see too. It's quite dramatic. And then what we're going to be talking about today is insufficiency fractures in the pelvis and sacrum. By the way, these can happen anywhere in the body, but we're going to focus in these areas today. These are not commonly associated with BP use, and they're often missed. And I have seen many cases of this, and it's not something that medical doctors typically will associate with medications such as Fosamax again or the bisphosphonates. So are doctors who prescribe these medications getting the message? That's really the question. And I'm going to bring on now Sandi Putnam. Are you there, Sandi?
I'm here, Dr. Lani.
Oh, great. Well, welcome to the show today.
Thank you.
So, what we want to talk about first is your story and your story before you started taking the drug Fosamax. So, I have this picture of you, Sandi, when you were a little girl. You never sustained a fracture, right, in your life?
Never, never.
So, you were a healthy little girl, never fractured a bone. Were you active?
Very active.
Oh, and here we have pictures of you riding horses. So, when did you start horseback riding?
I started horseback riding at age 52.
Oh, wow.
That was my childhood dream. If you look at that previous picture, I'm wearing a shirt with a horse on it.
Oh, you are. So this was before Fosamax. We have another picture. So what's your horse's name in this picture?
Okay, that's Miss Oak Chex. She's a quarter horse, and I had her for 20 years.
Then we have you doing what here?
Looks like a headstand, but it's actually a shoulder stand on the two chairs.
Okay, but I would say you look like you must be pretty strong there to be able to do that.
Well, I have to admit I had a little help.
But the point is, you were strong, you could do things, you were active, all your life, correct?
Yes.
Now we want to talk about your experience after Fosamax. Of course, your life changed dramatically. So when were you told that you had a problem with your bones. How old were you? So give us a little bit about that.
Well, my doctor, when I was age 63, he decided it was time for me to have a bone density, which we did. And it showed scores of minus 2.1 in the spine and a minus 2.3 in the hip. And he didn't classify that as osteopenia or even say osteoporosis. He just said it's probably time that you start taking a bone drug because he said you don't want to fall and break your hip and die. And I agreed.
Yeah, well, that's kind of scary. And this, by the way, still is not uncommon today, that people are put on medications for this. But what it should have happened, which I'll talk more about later, is a whole bunch of other tests should have happened at this time. Remember, she had never had a fracture, and that tells the doctor a lot. If they haven't had any fractures at all in their lifetime, that means that she might have low density, but the quality of her bone is good. Do you have big bones or kind of smallish
I'm
bones?
rather small boned.
Okay, so that also means that the bone density is somewhat what we call false positive reading, meaning that if you have small bones, you're going to have less than an average bone density because when we're measured up against a group of people to determine our bone density, it's against an average 30-year-old. So if you have smaller bones, you're going to come in a little lower. It doesn't mean you've lost bone. So the diagnosis, even of osteoporosis, doesn't mean that active bone loss is occurring. I'll talk more about that later, but that is what we really want to go after. It's a static test. So you don't even know if bone loss is occurring. So keep that in mind. All right. So how were you informed and what was the diagnosis based on in your case? Was it based only on the bone density or did the doctor do more?
Well, I just remember we had this conversation in his office after I'd had the DEXA scan, and I don't think he even gave me a diagnosis. He just said, it's time for you to do a drug, and there was no other testing.
Okay. So no other testing. And how did you feel when you were told that you had the bone problem?
Well, I don't remember that I felt frightened or scared or upset. It was just like compliant and respectful of my doctor. You just do what he says.
And that's unfortunately the case with a lot of people. They pretty much just listen to what their doctors say and do what they're supposed to do. So, what medication did you take?
Well, he put me on Fosamax, and at that time it was a daily dose, which was really a pain to have to do that and wait for a half an hour before you could do anything else. And then shortly thereafter, he added Evista. So he had me on those two drugs at the same time because he said, I'm the doctor and I can do that. And he just wanted to add an extra punch. I stayed on that for about 3 years, the combination, and something in my gut just said, "I don't understand why I'm on 2 drugs doing the same thing," and since then, I think it's been found out that this is not a good combination.
Not only is it not a good combination, but it wouldn't have done any benefit, and also there is an increased risk of other things. So, all medications, I mean, there's no free lunch, as we know, and medications have side effects. And a lot of the side effects do not come to light until thousands and hundreds of thousands of people have been taking them for a long time. So, anyway, you stopped the Avist eventually on your own. So, how often were you monitored with lab tests? Because when you are on a medication for bone, there should be a whole host of lab tests that are done beforehand to determine A, are you actively losing bone? And also, are there secondary causes if you are losing bone that should be resolved? Because if you just take a drug, you haven't plugged the hole. So, did your doctor follow you with any lab tests such as the bone markers?
I don't think even people were talking about bone markers back in 2003, and the only lab testing I remember is, an occasional blood panel, but nothing that was ever related to bone health. And although I do recall when in my sixth year on Fosamax, we did a vitamin D level
Okay.
and it was low, it was 27.
Well, I think you're right that in 2003, most doctors were not doing other testing, but a lot of us were. So that's true. When did you first find out that you were having a problem with the medication?
Well, I never knew I had a problem with the medication until into the 10th year of Fosamax in 2012 when I had some other issues that we thought were related to spinal stenosis. He actually renewed my prescription for alendronate. I took one and I had more of one of those gut feelings that just said, I think I should be stopping this drug.
Yeah, and this is what's so stunning when you hear stories like yours is that it's really kind of coming from you rather than the doctor that this might not be a good thing. And remember earlier I was talking about how bones stay healthy is that every 7 years the body kind of renews itself by those osteoclasts getting rid of old bone. Well, now Sandy's been on this drug for 10 years, and we now know we've known for a long time, by the way. This is not new news. It wasn't new news back in 2012. It wasn't new news in 2006. If anybody was reading the papers that were coming out, to have some caution about prescribing these drugs, especially for any length of time over 3 years. And when were you told that you sustained fractures?
Well, it goes back to May of 2012 when I was having some incredible pain, and we attributed it to spinal stenosis. But it took almost 2 months for me to get a CT scan that showed up fractures in my pubic ramus and in the sacrum. And those happened without any traumatic event whatsoever. I didn't twist, I didn't turn, I didn't sneeze, I didn't fall down.
So that's the, and I'm going to show what these fractures look like because I myself looked through the MRIs and the CT scans to find them. And so this is what we're referring to again as an insufficiency fracture. The definition of an insufficiency fracture is a fracture that occurs basically under your own body weight. Now, these can happen, these kinds of fractures can happen in people who have severe osteoporosis who've never been on these drugs and their bones are in that bad a shape. Or, like, again, lifelong smokers, alcoholics, things like that, or drug users, a lot of times that can be part of that too. But it can also happen when these drugs are used inappropriately. They're not followed with lab work and they're given to people too long. And so these insufficiency fractures are things that we are seeing, but the doctors who are seeing these fractures aren't getting the connection. What did your doctors say about the insufficiency fracture?
Well, after the CT scan, I got a phone call from one of the women in the office, and she said, you have a fracture in your pelvis and you have a couple of fractures in your sacrum.
Oh, that's
And
great. You got a phone call from the desk person. The
yes,
doctor didn't even bother to call you.
no.
That's pretty stunning.
And subsequently, he never discussed these with me. And it was me who saw that those words written on my copy of the DEXA scan.
And why don't you tell us what happened to your life after you had these fractures and how did you deal with it? Because these are not, as you'll see in a moment, these are not minor fractures. You can't sit with the kind of fracture she had, literally. And the kind of pain she had, you might want to describe how you would describe your pain to the doctors.
Well, I started out, it was about mid May, and I had what I thought was a sciatica in one leg. And then a couple weeks later, I got more of the same in the other leg. And by the early part of June, when I saw my doctor, maybe for the second time, I was no longer able to sit down. And so I used to laugh going into the doctor's office. They'd say, well, have a seat. I'd say, no, thank you. Um, so I couldn't sit, I could barely walk. I had pain in my legs, my thighs. I had pain in my groin. My tailbone felt like it was on fire. My hips hurt. And because of two MRIs that we had, this pretty much seemed to indicate I had a
Well,
bad case of,
yeah,
yeah,
we're going to
spinal
go into those.
stenosis.
Yeah, we're going to go into those, and but what I can tell you is in terms of the stenosis that you had, which you did have, it still shouldn't have. Well, we're going to show what happened here because actually, on the first MRI, the radiologist completely missed the obvious fracture she had in her sacrum. So we'll get to that in a minute. Um, but let's just say that this took a chunk out of your life. And uh, I would imagine it would make life difficult to live for quite a long time.
Well, I had about 3 months that I could barely walk. I couldn't sit. I had to give up my horseback riding. Um, I was I was pretty much an invalid.
And then it takes a long time to even get back to any kind of normal. But when did you first realize that the fractures were due to long term Fosamax use?
Well, I pretty much came to that conclusion on my own because I say because of my appointments with Dr. Google. Um, we have all this information on the internet that once you begin seeing the same information repeated over and over again, you think, well, this sounds valid to me.
So I guess your doctor never talked with Dr. Google or you know I mean, it's true. It is everywhere, and this is what's so amazing. Because what kind of doctor was this, by the way? Was it a
He
general
was a
practitioner?
family practice. He was family
That's
practice
part of the
doctor.
problem too, because people say, "Well, what kind of doctor should I go to?" Well, it could be a family practice doctor if they have taken the level of time, like say I have taken years and years and years of study to understand bone. Um, More likely, you're going to find an endocrinologist that will do that, but not necessarily that either. So but I can tell you that for the most part, a general practitioner does not know how to assess a, for the most part, a general practitioner does not know the right lab test to order, and they're just applying a drug to the diagnosis. And that's the problem, rather than looking at the diagnosis and getting interested about the diagnosis. Um, So, did your doctor agree, in fact, that your fractures were likely the result of the long term use of Fosamax? Did you point that out to the doctor?
He never discussed that with me on any level.
Did
He
you
never,
try, well, once you realized it, did you try to get to him and say, hey, maybe it's because I've been doing the drugs you've been prescribing me too long?
well, I didn't do that, and I feel stupid now that I didn't. Um, but I left him. I had I told him I had started taking a magnesium supplement, and he made me feel like I was a complete idiot. So I thought, I'm out of here.
Yeah, unfortunately, that's the way it often goes. And how are you now?
Well, I can say I'm back to about 90 to 95% of my former self, and maybe exactly where I would be anyway, but I would have liked to have gotten here a little more gracefully.
Because had she not taken yet another drug for 2 years, she would not be where she is today. I can tell you that right now. You would likely be in a nursing home if you had not taken the second drug to reverse this problem. How did you end up being prescribed Forteo?
Well, that doctor, my primary doctor, he mentioned, Forteo was probably my only drug of choice and that I would have to inject every day. But he said, you can do this. And so I thought, well, yes, I can do this. And then I saw the endocrinologist, and he did an evaluation, I think, to rule out any parathyroid issues to make me a solid candidate for this drug.
And this is the only drug. So Forteo increases both osteoclast and osteoblast action. So the two bone cells will become very active on Forteo. Another big difference about Forteo is it doesn't get entwined in the bone itself. Fosamax does, and the bisphosphonates actually are in the bone. Whereas Forteo has what we call a half-life of seconds, and it just you know goes through the body very quickly, and it upregulates both osteoclasts and osteoblasts. But in the end, the osteoblasts outpace the osteoclasts. So why this drug is so good for people who are in the situation, or who you know and it can help them, which it did with Sandi, reverse her situation, is because it got rid of a lot of the old bone and laid down new bone. But had she not taken this drug, her bones were so fragile, the bone quality was so bad that she could have ended up with a femur fracture that you learned about with Dr. Schneider in my last webinar. So how long did you take Forteo?
I ended up taking Forteo. It took me nearly 3 years because my serum calcium became elevated on this drug, which is a lot more common than what people are willing to admit. So I went to what they call intermittent dosing. So sometimes I would take off 2 months, sometimes I took off 3 months till my serum calcium went back down to normal.
And that's good that the doctor was following that closely. Not only serum calcium, but another test called ionized calcium. Both of them are inexpensive, but ionized calcium is an important one to do during this time too, as well as bone markers and other things that I would do. But absolutely, you got to keep tabs on that serum calcium to make sure it's not getting too high in the blood. Serum calcium that's elevated or high end of normal is never a good thing. Um, did you have any side effects?
Well, in the beginning, when I started to inject, I remember feeling very kind of weak and hard to put one foot in front of the other one. So I started then injecting my drug before I went to bed, and then it didn't matter. But in time, I switched it around to mornings just so I could get it done. And oh, the other side effect I had, which people want to deny, is that I had some hair loss. And I thought, oh, I'm not going to fight with this. I just went out and bought a cute wig. But in about 2 months' time, that all cleared up.
Okay, good. Well, like I say, there's side effects to everything, and some people cannot do Forteo, take Forteo. But Forteo, because it actually stimulates the body to build our own bone, is unique. It's an anabolic drug, and that means that it actually builds bone. Whereas all other drugs in this country are only our anti-resorptive drugs are only impacting the osteoclasts in one way or another, even Prolia, as I said. So when doctors switch you, they say, oh, you've been on Fosamax too long. We're going to switch you to Prolia. That's not a switch. That's the same. It's going to do the same thing, and you could potentially end up in the same situation that Sandy's in. Um, uh, if you're taking these drugs longer than 3 years. And of course, from my perspective, do you need to be on them at all? So, I mean, I'm not even going there today. I'm just going to be really well accepted to say a lot of people I see don't even need to be on any medications. They need to be on good nutrition. All patients should be. The basis of all treatment programs should be solid nutrition, gastrointestinal health, and yes, there are cases where medications are needed. That would make sense, but not the way it's being done now with so many people being put on these drugs, uh, all just based on a diagnosis and no other look into it. Basically, what do you do now to help your bones besides Forteo?
I'm on a what I call a bone healthy food and beverage intake, and I have a very disciplined adherence to the supplements that benefit bone health. I walk a mile and a half every day with my 7 pound weight belt. I go to curves 3 times a week and yoga once a week. And in the summertime, I indulge in non-weight bearing exercise called swimming because I get in a half a mile of laps every day. It's aerobic and I can soak up some more vitamin D.
Yeah, I think, swimming gets a bad rap, but you know what? All exercise is good. And it may not be weight bearing, but people who love swimming, it's an also, I think for a lot of people, it's an antidepressant, a natural antidepressant. It's a great, swimming is great. I don't like swimming myself, but if you like swimming, enjoy it.
Well, I
Okay.
think I was born with fins.
Okay. I want to do a recap of what went wrong. First, she was prescribed a medication based on a bone density test alone, and she was prescribed a medication that she did not need. She was prescribed a medication that she did not need in the first place. The doctor did not follow her with proper lab tests to determine whether or not the medications were having a deleterious effect. The diagnosis of osteopenia was not an indication in and of itself that Sandi had weak bones. Sandi was in excruciating pain in 2011. She had an MRI, and the radiologist missed an obvious complete fracture of her sacrum, which I will be showing in a moment. The second MRI in July noted the fracture but minimized the damage and mentioned that it was not in the previous MRI, which was not true. So it was blatantly in the first MRI, and the radiologist wanted to make the point in the second MRI that it wasn't there, and it most certainly was. Um, she finally was prescribed Forteo in October. So this whole thing in terms of her MRI started in June of 2011, and she wasn't prescribed Forteo until October. So this bungling around of everybody caused her to wait that long, and I am just amazed nothing worse happened to her because I want to say this very clearly, an insufficiency fracture is an emergency situation, and I am hoping, really hoping that we can change the national conversation about this and get this clear to doctors. If somebody breaks a bone, and I don't care what reason it is, under their own body weight or from sneezing, they need to be assessed immediately. And if they can be, and if they've been on these, and if it's because they've been on these drugs for a long time, and they can be cleared to take Forteo, it should happen as soon as possible. So the take-home message: none of this should have happened, and Sandi had a doctor Sandi had a doctor who fully understood how to assess bone health. Lab tests, nutritional analysis, and more are necessary in addition to bone density testing to assess bone health and, of course, common sense. What kind of fracture did Sandi sustain? So again, we're talking about an insufficiency fracture, which is in a subgroup of stress fracture. So there's another type called a fatigue fracture. But an insufficiency fracture is caused by normal physiologic stress, like standing upon a weakened bone, and so it's loss of the tuberculi inside the bone, which you'll see in a moment, that decreases the bone's elastic resistance. Sandi's fracture, there was no trauma. Again, she suffered multiple ones, so we're going to look at these now. She had a complete fracture of the sacrum. She had a pubic bone fracture that was complete, and both of these were displaced. When they say mildly displaced, well, okay, so it might be a mild displacement, but they are complete fractures. Two additional fractures in the sacrum and the alar region that were vertical, and she had a vertebral fracture, but we're not sure that this was caused during this time and likely may have happened earlier in life. So to give us a sense about spinal anatomy, what we're going to be talking about is the pelvis, and you can see that L1 and L4 are circled there, and you'll also see that the forearm is circled there and the hip is circled. These are the areas that are tested for bone density, the only areas. And the reason the L1 to L4 are tested is because there's no other bones in the way. But we're going to be looking at today for Sandi's fracture is that pelvis region and the sacrum. which is the bone that is right in between the pelvis there. So when we look at insufficiency fractures, this is where they can occur. So they can occur anywhere. They can occur in ribs. If you look at the sacrum there, and this is exactly where Sandi had her fractures. The straight up and down ones, she had both of those on both sides, and the one with the line that goes straight across in the circled area there, that is exactly where hers fractured. And here is the June 11, 2012 MRI report. There's a herniated disc there. So this is looking at Sandi from the side, okay? And I think anybody here, even if you don't know anatomy too much, you can see that circled fracture, which to a radiologist should be blatant, but it wasn't. In fact, this was missed. In July 20th, another MRI was performed, and he made the point that this area was not included, but that was absolutely not true. And here it is again in July, more close up of the complete sacral fracture. But that's the sacrum, and it's completely displaced. This is Sandi's pelvis, looking at it from the front from a CT scan. So I just wanted to orient you, because now I'm going to be so you can see the spine right up above there, and then these are the pelvic bones here. And then what we have is the pubic bone, which is right in the front. We all have that, and that's a complete fracture there. The other fractures that Sandi had, again, were the bilateral sacral alar fractures, which were vertical. She had that transverse fracture, meaning straight across of the sacral S1 and S2 regions, and it was completely displaced. So this is like snapping your sacrum in half, and there's nerves in there. So that was what was causing both legs pain. That was what was causing the burning sensation, not that herniated disc. And the left pubic bone was completely fractured and displaced. And again, the thing that is just so egregious to me is that she had to wait. And I think you told me last night when we were talking, because I'm still so stunned about this. Once you did get to an endocrinologist, they made you wait another 2 months for an appointment.
Exactly.
Did they know you had these fractures?
Yes.
And I want to ask you, why weren't you pushing this more at this point?
Well, I didn't know. I didn't know what the protocol is, and I had no idea, actually, till lately, talking with you, how severe these fractures actually were.
But you're not quite that same way now. I mean, I think that you come out of that era where everyone, and I still think a lot of people do. They just listen to their doctors, and there's some kind of God. But you're not like that anymore, right?
Well, I hope my new doctor's happy to put up with me.
So here's where, is this where you convalesced? That's what I imagined.
Well, I got to that room once in a while, but that was the computer room, and I couldn't sit down, so I spent 5 minutes at a time standing at the computer.
Any words of wisdom for our audience that you would like to share?
Well, looking back now, I would say start a journal. Just write down all of your symptoms, your interactions with your doctors, keep copies of all your lab tests, your blood work, get your MRI on a disc. Then read and study, and you have to own your information. You have to be the one driving the bus.
And I really want to underscore the importance of getting hard copies of all your test results, because when somebody comes to me, I want to have copies of everything, the entire bone density report. And there's a page on my website that tells you how to ask for that. So you want to get not just the written report, but when you're coming to someone like me, you're getting a second opinion. Every time you get test results, lab results, you want copies for yourself. And then when you come to someone like me or somebody else for a second opinion, you want to make copies of everything in a binder and give it to them, because you want their best thinking. And then you say, here, you want to evaluate your doctor. So what would you have to say about that, Sandi?
Well, is my doctor trying to find out why I have bone loss. Don't just come at me with a prescription based on a single bone density test. Let's find out why we have this. Let's fix that first. And you've made that so clear in your book that we need to find out how many of those 100 reasons we have to that we've got bone loss in the first place.
R-
Then we need to do exercise and supplements, and hopefully our doctor will use a bone drug as a last resort.
Right. And I think that for a lot of people, they're not going to find what they need in one doctor. And what I would say about that is, you really do. A lot of my patients, they really obviously need a very good medical doctor. And you want a good medical doctor who is willing to do the lab work and as you say, um, assess the labs. Although in California, chiropractors can do that too, and naturopaths and so forth. But they still have to be somebody who's steeped in the knowledge of bone to be able to do that. And on the other hand, I would really also caution people not to uh, or to be aware of, say, supplement companies or people selling supplements and saying, oh, we've reversed our bone density 30% by being on this supplement. Um, and I just get really aggravated with that. In fact, one of the big ones for me, of course, is strontium. I will do a future webinar on that. And uh, strontium can increase bone density. The question is, what's the quality of that bone? But also, again, you don't want to take strontium is a drug. If you buy strontium in a health food store, uh, even though it's not prescribed, it is, trust me, it's a drug. It's in your bone for the rest of your life, so it better be doing a good thing. And you never, ever take that or anything else before you've been assessed properly. And as Sandy just mentioned, one bone density test does not mean you're losing bone. You could have two bone density tests, usually done 2 years apart, that will show that there has been bone loss if it was done right. So let's just say two bone density tests that have been done correctly and compared correctly. Uh, and if in fact it's showing that you're losing 6%, then you're probably losing bone. But by the way, there's so many errors that it can be made. A lot of these are incorrect when they say that you're losing bone or gaining bone for that matter. So we do have a few questions from our audience. One of the questions was, at what level of osteopenia do you consider it a good idea to take Fosamax or others? But let me give you another little thought. Let's say you have somebody who is a big bone person. You got a woman, say, who's 5'8", and she has big bones and, good size. Now she has osteopenia. There may be a problem because her bones density should be much thicker. Remember, they do not measure us against our own body type people. It's against an average person. So that's when I get concerned. Then another person said that they have bone density of a negative 4.2. Do I basically consider that a problem? Yes, I do. So if you truly have a negative 4.2, that is a point at which a lot of lab work should be done. Again, are you actively losing? Or is this a problem that you had earlier? Maybe you had eating disorder early on in life. There's a lot of reasons. But negative 4.2 absolutely has my attention. Negative 3 has my attention. Negative 2.5 has my attention. But again, that requires additional testing. And then somebody thanks us both for great informative webinars. Thank you. That's great. And then somebody else wanted to ask you, Sandy, if you're taking vitamin K.
You better believe it. I'm taking vitamin K2. I found one that's got both the MK7 and the MK4 in combination, so I think I'm covering all the bases.
Well, I'm going to do actually a webinar in the near future on vitamin K with the woman who wrote the book on it. So we'll get a lot more information on the MK4s and the MK7s at that time. And then there was another question about calcium. And since your calcium, blood calcium is high or has been high, how do you deal with that, Sandy?
Well, I have not had a calcium supplement for now more than 2 years. And my new doctor, I'm so encouraged. He just said, get all of your calcium from food sources. And he doesn't necessarily recommend a supplement.
Yeah, and I want people to hear that because that is true of some people, but I also want people to understand that a lot of people do need calcium supplements, which is why people need to be evaluated individually. So Sandy doesn't need that. I do. So, because I can't eat dairy and I thought I could get everything from my food, and I lost 6% bone density over a 2 to 3 year period with that experiment. So, again, your bones are your bones. You arrived at where you are in life with your own set of bones. And that's why we have to look at people individually and do a very good assessment, including a 7 day food diary, is what your doctor should be asking you to fill out for them. Okay, well, Sandy, I really want to thank you for being here because working with you on this case, we've been working on this for a couple weeks now, and I really want to get the word out about insufficiency fractures. Nobody's talking about this, so I want to thank you.
Well, thank you, Dr. Lani. You've been a tremendous help to me.
All right, well, we're signing off now, and have a good day. All right, bye bye.